Well, greetings everyone and welcome to the EKG case for the week of March 25th, 2013. Before we get started, I just want to put one more shameless plug in for the resuscitation conference that we're conducting in Las Vegas, May 1st through May 5th. Please take a look at that website. We've got some awesome sessions by some nationally renowned speakers that are going to be at the conference, including, if you want more EKGs, Jeff Tabus, who is a fantastic EKG teacher, IM trained, super nice guy out from UC San Francisco. He's going to be there and hope to see you there. Okay, let's get going with the case for this week. And this week's case was sent by a paramedic by the name of Matt. Now, Matt was a little bit shy about putting his personal identification, his name and where he works and everything. I think he was afraid of the paparazzi following him around by posting his name and everything. So anyway, but my thanks to Matt for sending actually two cases that we're going to go through this week. And here is the first case. I don't have the age and the patient presentation, but let's just pretend that this is a person coming in with chest pain. And I'm pretty sure it was chest pain. And here's the 12-lead EKG that Matt had sent to share with us. And there's a handful of abnormalities here. There's no surprise, first of all. There's ST segment depression in a bunch of leads. Actually, before we even get there, let's just do a little bit of basics here. Take a look at the rhythm. And you'll notice that the P waves in lead 2 and in lead 3 and in lead AVF are all inverted, and the P wave in AVR is upright. Now, all four of those things that I just pointed out are abnormal. The P waves should be upright in 2, in 3, in AVF, and inverted in AVR in order to call this sinus rhythm. So in this particular case, because of the P wave morphology, this is an ectopic atrial rhythm. Okay? What are you going to do with that? Nothing. But I figured it's worth mentioning when you see these inverted P waves. Think about an ectopic atrial rhythm if they have a normal PR. If they have a short PR, you're going to think of junctional rhythm. Anyway, we're getting off the topic, so let's get back to the 12-lead and the chest pain story. And what you'll notice here is that there's a lot of ST segment depression in a handful of leads. There's some subtle ST depression, and maybe in 1 and maybe in 2 and 3, flip T wave in 3 and AVF, little ST depression in AVF also. But hopefully what's really jumping out at you is the ST segment depression in the precordial leads. Let's blow that up, in fact, and just focus on the precordial leads. You'll notice that there's ST segment depression in V2, NV3, NV4, NV5, NV6. Pretty much everywhere. V1's kind of feeling a little bit left out. We're not going to look at V1 because that's kind of looking normal. We're going to focus on the abnormalities in V2, V3, and V4. Now, there's something extra special about this ST segment depression. You'll notice that the J points are depressed in all of these areas. And not only is there ST segment depression in all of these leads, but there's also a fairly unusual upsloping ST segment depression, which goes into a big T wave. All right. So the J point is a little bit depressed, and there's upsloping ST segment going up into a tall symmetric T wave, ST segment upsloping depression going into a tall symmetric T wave in those precordial leads. I'm not going to trace all of them, but hopefully you appreciate that abnormality, and that has been described before as something that we now refer to as the Dewntter T waves. And when you see T waves that look like that, again, there's ST segment depression and also with upsloping ST segment depression as opposed to horizontal. There's upsloping ST segment depression going into tall symmetric T waves. When you see that, that's been described by somebody named, a handful of cardiologists actually, but it's been named after the first author of the original paper, Dewintter's. And these Dewntter T waves are highly predictive of an LAD occlusion. Now, what's a bit unusual here is that when it was first described in a letter to the editor of New England Journal a few years ago, it was described as, number one, highly predictive of acute LAD occlusion, not chronic, but acute LAD occlusion. And it was originally described as a somewhat static or unchanging abnormality. Well, we've come to discover through some of our own cases and through this case is that if you repeat the 12 lead, you sometimes will see this evolve into a full-blown STEMI. And in this particular case, that's what we're going to see. We repeat the 12 lead about 90 minutes later, and here you have a full-blown ST segment elevation, MI. This person clearly goes to the cath lab. Now, we've argued and actually published this in American Heart Journal that the Dewntter T waves is probably what we call a STEMI equivalent. In other words, when you see the Dewntter T waves, even with the ST segment depression, this should probably qualify for going directly to the cath lab. Now, this is not in the national guidelines, not in the European guidelines either, to my knowledge. However, I think with time, as more publications come out about this Dewntter T-wave abnormality, hopefully we'll get to the point that emergency physicians and especially the cardiologists will look at this and they'll say this person has an acute LAD occlusion. They need to go to the cath lab. But right now, a lot of cardiologists may not take this person to the cath lab. Instead, you lose time and you end up having to repeat the 12 lead a little bit later, at which point now you see clear-cut ST segment elevation MI. Anyway, this patient ended up doing okay. They repeat the 12 lead 90 minutes later, and there's a no-brainer anterior wall STEMI. This patient did go to the cath lab and was found to have, no surprise, an acute LAD occlusion. The patient fortunately ended up doing okay. So, first takeaway point in this, remember the Dewntter T waves. Okay, there's ST segment depression that's upsloping, and it slopes up into a tall symmetric T wave in the mid-precordial leads. When you see that in a person who's got some cardiac complaints, you need to worry that they have an acute LAD occlusion. All right, we've talked before about Wellen syndrome, and that predicts proximal LAD occlusion, but that tends to be a bit more subacute. This is an acute abnormality. Okay, Matt sent us another case also, and he provided a little clinical information with this one. Case 2, 68-year-old woman who presented to the emergency department complaining of chest pain that was radiating to her back and to her arm, and she was also hypotensive with a blood pressure, systolic blood pressure of 80, and the patient was describing it as indigestion and thinking that it's indigestion. And whenever you hear the word indigestion, especially from me, what it means is that the patient's having a STEMI, right? Indigestion, please be careful of indigestion. There are studies out there indicating, in fact, that elderly patients with acute coronary syndrome oftentimes will, even young patients, will describe their cardiac pain as a burning or reflux or indigestion type of pain. And if you look at the medical legal literature, indigestion or reflux esophagitis, peptic ulcer disease, these are the most common misdiagnoses sitting on the chart of missed cases of MI and malpractice cases for missed MI. So as I tell our residents, anytime you've got a patient with chest pain and you write reflux on the discharge diagnosis, just slap yourself. Slap yourself silly, because if you don't, a lawyer will. Indigestion, reflux, peptic ulcer disease, be very careful about ever using that as a discharge diagnosis. Just think twice. All right. Anyway, this patient thought she had indigestion, but they got a 12-lead EKG. And again, you notice a handful of abnormalities in multiple leads. There's ST segment depression in lead 1 and in 2 and in AVL, maybe a little bit in AVF, and in V2, V3, V4, V5, V6. In other words, a whole bunch of leads have ST segment depression. There's 2 leads that have ST elevation. There's V1 and AVR. Now, these technically are not considered contiguous leads, but you may recall we've talked about this before. We've talked about comparing the two before. We've talked especially about lead AVR, in that when you see ST segment elevation in AVR, it is highly predictive of a left main coronary artery stenosis or occlusion, especially when this occurs in a chest pain patient who also has ST depression in multiple other leads. All right. Well, the physicians that were taking care of this patient didn't necessarily do anything immediately with this. What they did was they repeated the 12-lead EKG just moments later, which is always very reasonable to repeat the 12-lead and see if anything is evolving. And what you see on the repeat 12-lead, again, there's still ST segment depression in a whole bunch of leads. There's also some PVCs that you've seen here And Matt pointed something very interesting about the PVCs. Normally, this is a normal PVC, all right? Just take a look at that for a second. In a normal PVC, you have discordance of the QRS and the T wave. In other words, when the QRS goes up, the T wave usually is depressed, the ST segment's depressed, and the T wave is inverted. When the QRS goes down in a PVC, you usually have a little ST elevation and an upright T wave. My drawing's pretty bad, I know. So it's kind of like a left bundle, right? We've learned about discordance with the left bundle. And if you don't have discordance with the left bundle, you've got to worry about it. Turns out that in a chest pain patient, when you don't have discordance of the PVCs, that can also sometimes tell you or give you a hint that something bad is going on. And if you take a look at some of these PVCs, take a look here, there's a PVC, and the J point is just a little bit below the baseline in the same direction as the QRS. Here's another PVC. The QRS goes down, you expect the ST segment to be elevated. It's not. The J point's just a little bit depressed. Here's another PVC. The QRS goes down, you expect the J point to be a little bit above the baseline, but it's not. It's actually discordant in the same direction as the QRS, and the same thing is occurring in lead V3 as well. So these PVCs are unmasking some hidden ischemia. And so that's just an interesting finding. Hopefully you're already focused on the ST elevation and AVR. So anyway, there's a couple of interesting things here. There's ST segment elevation and AVR in the presence of a lot of other ST depression. The ST elevation in AVR is greater than the ST segment elevation in V1, right? There's a few millimeters of elevation in AVR and maybe just a couple, maybe 1 millimeter of elevation in lead V1. And we have described that before as highly predictive of left main coronary occlusion. So the physicians that were taking care of this patient immediately activated the cath lab. CLA is cath lab activation. And the patient, who is hypotensive and heading towards shock, was found to have a left main coronary artery occlusion. Fortunately, the patient ended up doing well. But I thought this was a really interesting EKG, and actually Matt pointed this out for us even before sending it in that the patient has the ST elevation and AVR in the presence of a lot of other ST depression, and this AVR is greater than the ST elevation in V1, and then in the subsequent EKG, there is the loss of discordance between the QRS complexes and the ST segments in those PVCs. And both of those are indicative of something bad going on. So anyway, this case too did fortunately have a good outcome and predicted a left main coronary artery occlusion based on that elevation in AVR. So let's quickly sum things up. I know we've gone quickly through these two cases. Please review them if there's anything confusing, and I'm going to give you some more references here, more information that you can go to. So the first case, we talked about these Dewntter T waves. Again, the QRS, and again, please excuse my horrendous drawing, but the QRS is associated with ST depression that's upsloping, and then it shoots up into a tall symmetric T wave. That's a bit exaggerated what I just drew. But when you see that in the mid-precordial leads, you need to worry about an acute occlusion of the LAD. And we're now starting to see some cases where if you don't send these patients to the cath lab but repeat the EKG, you may actually see a STEMI develop. And if you want more information about the Dewntter T waves, take a look at the March 11th, 2012 EKG case that we did. Just go to the website www.ekg.umem.org, which is a website on the first slide here, and go back to March 11th, 2012 for more information about that. And the left main coronary artery occlusion, we've talked about that back on November 13th, 2011. We went through a whole bunch of cases back then, and what we talked about is the fact that if you have ST elevation and AVR in conjunction with ST depression in multiple other leads, all right, And especially if the ST elevation in AVR is greater than the ST elevation in V1, that's highly predictive of left main coronary artery occlusion. Those patients are at high risk for developing cardiogenic shock. This patient was already heading towards a shock state, and fortunately the physicians and Matt got this patient up to the cath lab very, very quickly. So my thanks once again for Matt for sending a couple great cases. Take a look, March 11th, 2012 and November 13th, 2011, if you are not familiar with Dewntter T waves and left main coronary artery occlusion findings in AVR. Hope that was helpful, and I look forward to talking to you next week. Bye for now.